All right. Hello, everyone. Good afternoon. I'm Laura Weidner. I am Chief Advocacy and Government Relations Officer at the Epilepsy Foundation. My pronouns are she, her. I'm a white woman with reddish straight hair wearing an orange dress today. I'm delighted to be here with you this afternoon and to moderate this great panel. Network adequacy ensures that people have timely, meaningful access to health care and services they need, as well as accurate information to enable people to understand plans' networks and identify the plans and providers most likely to meet their needs. For people with epilepsy, for instance, it's vital that people can make sure that their epileptologist or neurologist and other providers, which could include rehab therapists, neuropsychiatrists, neurosurgeons, psychologists, or psychiatrists, just to name a few, are in network and easily accessible. Delays to care and treatment for people with epilepsy can result in breakthrough seizures, which can cause injury, disability, or even death. So this is an issue that's important to my organization, and I know so many people with acute and chronic health conditions and people with disabilities, and any consumer, honestly. Federal law and standards related to network adequacy have come a long way. For instance, marketplace plans must meet concrete time and distance rules and standards, specifying the maximum number of days enrollees are required to wait for an appointment. Oversight and compliance methods are being put in place to make sure consumers are in fact protected. However, as most areas of healthcare, despite progress, there's always room for improvement. Our panelists today will discuss network adequacy as it stands now, and perhaps more importantly, some of the innovative approaches being looked at to ensure that network adequacy is meeting the health equity needs of consumers. So my role is pretty easy. I'm going to intro our experts here on the panel, and then we'll let them speak, and we'll have time for Q&A at the end. So make sure you think of some great questions. Our first panelist is Subhash Seelam. He is the Senior Vice President of Applied Network Analytics at Quest Analytics. With over 2 decades of experience in building data models within the healthcare industry, Mr. Seelam is a vanguard in the field, adept at weaving intricate stories from diverse data sets, ranging from government-generated to transactional claims data. His unique ability to distill compelling narratives from complex information has empowered stakeholders to make informed and insightful decisions. Mr. Seelam tenured at Optum, where he served as the head of advanced analytics and clinical insights. He's continued his data analytics work within the network analytics team at Quest Analytics, where he is currently exploring the integration of health equity provider characteristics into network adequacy metrics. We also have with us today Cheryl Fish-Parcham. Cheryl is Director of Private Coverage at Families USA, a nonprofit, nonpartisan voice for health consumers. In this role, she focuses on national and state policies that would improve access to coverage and care, including those related to behavioral health services. Over the years, her advocacy has included work on various provisions of the Affordable Care Act, managed care consumer protections, and protections for workers following job loss. Cheryl serves on advisory committees to the DC Department of Insurance and the DC Healthcare Ombudsman. She's previously served as Families USA's Associate Director of Health Policy and helped establish the Health Assistance Partnership, a national support center for consumer health assistance programs. Earlier in her career, Cheryl worked as an advocate at AARP's Legal Counsel for the Elderly and served as an advocate, administrator, and social worker for several community organizations. We also have with us today Kyle Esdaille, who is principal researcher in the health division at AIR. He currently works on projects that incorporate health equity into healthcare access, developing provider directory requirements regulation, and implementing the Affordable Care Act within the federal marketplace. He has experience in healthcare consulting, health insurance, health IT, healthcare operations, customer service, and population health management. Prior to joining AIR, he has worked at the Washington, D.C. Health Benefit Exchange Authority implementing the Affordable Care Act in the small group market, at the Lewin Group supporting the Federal Health Exchange and state-based exchanges, and at Care First, Blue Cross Blue Shield as a consultant in the patient-centered medical home program, working with primary care providers to improve quality of care and reduce cost. Dr. Esdaille also has a research background working with Baltimore communities on environmental justice issues and experience working on overweight and obesity community-based participatory research projects within communities. Lastly, we have Erika Melman, who leads the Center for Consumer Information and Insurance Oversight, or CISO's Division of Insure Management and Operations, issuing regulations and technical guidance on health plan benefit design, certifying qualified health plans to be offered on the federally facilitated exchange, and coordinating across CMS for cross-cutting rulemaking. She oversees work to develop and deploy technical assistance and communication materials to states, health plans, and trade associations on the qualified health plan certification process. Ms. Melman previously served in various policy positions at CISO, as a management consultant at Duty First Consulting, and Bearing Point, now Deloitte Consulting, and as a research director at the Center for Public Policy Research, now the Schroeder Center at the College of William & Mary. I apologize for looking down so much, but there was no way I was going to memorize that. All of the esteemed experts we have with us today. So again, I'm going to turn it over to our panelists. They'll talk for about 40 minutes, and then we should have 10 to 15 minutes for Q&A. So I'll turn it over to the first panelist.
Not as tall as an introducer. Can you all hear me? Great. Well, thank you for that nice introduction. So yes, I'm from CMS, the center that manages the implementation of the Affordable Care Act. For the slides, or oh, there we go. Thank you. So most of my time is spent on thinking about certifying qualified health plans to be sold to consumers on the marketplace. One of my favorite parts of that is thinking about networks and network adequacy. So I'm very excited to be here talking about that today, and also to see that you all must be really interested in that topic as well, to have stayed so late on the second day of the conference. So I appreciate you all being here. So I'm going to talk a little bit about CMS's current methodology for assessing network adequacy on the marketplace. I'll talk a bit about some new standards that we're rolling out for the next plan year and how all of that relates to health equity. So if any of you have been in the Medicare Advantage space, our methodology for marketplace network adequacy should sound very familiar to you, because we modeled it off of Medicare Advantage's methodology. We have about 40 specialty types, provider specialty types that we look at. We added in a few for the marketplace population, just recognizing that that population has a little bit of a different composition than consumers that enroll in Medicare Advantage plans. So we added emergency care, behavioral health, and pediatric primary care. And what we look at is time and distance standards. So what is a time and distance standards? It's really just a way to quantify how far it takes you to get somewhere, you have to go to get somewhere, and how long it takes you to get there. So for example, I like to live no more than 5 minutes walking distance and a quarter mile from a coffee shop. The way that that relates in the network adequacy space is that there are certain time and distance standards that we've set for each of those specialties in varying different county types that should be the maximum that a consumer should have to travel, either time-wise or distance-wise, to access that particular provider. And the standards differ based on the particular specialty types. in particular, in very sparsely populated counties, it's common to perhaps not have a hospital in that county. And, people do have to travel quite a ways to access hospital care. So we've adjusted those time and distance standards for specialties based on the local patterns of care in particular counties. Where we're sitting right now, we're in Bethesda, Maryland, which is in Montgomery County. It's a very densely packed county. So, it's reasonable to set a time and distance standard of, say, 20 minutes or 20 miles to get to a provider because there's a plethora of providers around here. But we are very careful to adjust and tailor those standards to different types of counties and specialties. And I'm going to read off what our standard is because sometimes I even forget it. So I just want to make sure I get it right. So our target is that 90% of potential enrollees in a county have access to at least one provider from each provider type in the model without exceeding the time or distance standard for that provider type in that particular kind of county. And so I think the 5 types of counties that we look at are here. The large metro, so we're in a large metro right now. Metro, micro, rural, and then CX stands for counties of extreme access consideration. So that might be a county maybe on the Navajo reservation where you actually have to transport people by helicopter to access medical care. So they have very different standards than we would have here in Montgomery County. So that sounds really complicated, and it is. It's a lot of data analysis, but we have our research partners, Quest, who have a wonderful tool that we use to assess all of the data that comes to us to determine whether health plans are in or out of compliance with the time and distance standards. And the good news is that most plans are meeting these standards. Since the inception of the marketplace in 2014, there are very few plans that we haven't certified for approval so that they can be sold to consumers on the marketplace. Now, the authority for looking at network adequacy has volleyed between CMS and the states. So at first we had the authority, then it was deferred to the states for 5 years. So this is now our 3rd year. Then it came back to us. So this is now our 3rd year of using the current model that we have for network adequacy. So that's the good news. And if just to add on to that, if the plans are not meeting the time and distance standards, we look at whether there's a reasonable reason for that. So for example, there might be a provider supply shortage in a particular area. Or there might be providers that have just decided to withdraw from insurance in general and are not contracting with health plans. So we bake that into our analysis and we don't hold health plans accountable for that. When they're not meeting the criteria or just on the cusp, we work with them. And, if they're very close, we partner with them so that they can be on the marketplace. They may be in the process of getting contracts in place and are very close to that. So we do offer some flexibility there. The not so good news is that I think, if time and distance standards and ensuring the appropriate, geographic dispersion of providers was enough to meet consumers' needs, we probably all wouldn't be here today talking about health equity. It's a very complex web that determines whether consumers' needs are being met in the healthcare space. And we recognize that time and distance is one building block there. So we've actually rolled out some new standards for our next plan year. We're going to start looking at appointment wait times. So for example, health plans could have enough providers to meet our time and distance standards. But if they're consumers that are trying to get appointments and they're having to wait 3 months, 6 months, 9 months to the point where it's impacting their health, that's something that we want to dig into. And so we've set some standards for appointment wait times, and that's something that we'll be looking at in the upcoming plan year. Our time and distance standards also don't really take consumer variation into account. So, the time and distance standards, they're based on geographic driving distance, which makes the assumption that everyone has access to a car at any given time. They can jump in that car from their home. They can go to their appointment. From a practical standpoint, we know that's not true. There's people that don't have transportation, or they don't have reliable transportation. There are people that don't have, reliable housing. And so they may live different places. And even going back farther from that, there's people who may not even try and make an appointment in the first place because they have concerns that either the provider or the office staff won't be able to communicate them in the language that they're comfortable communicating in, or that there might be some other cultural barriers that would inhibit them from seeking care in the first place. And so sometimes there's such a critical mass of consumer characteristics that it really changes the nature of the geography of that particular geographic area or county. And so a county may have different needs than a neighboring county or the same type of county in another state. And so that's what we have started talking about with our research partners here. How can we as an agency bring to bear all of the various data that's available about consumer needs and barriers to identify geographic areas of high need? And how can we use that information to influence the composition of networks to meet that need? So I think, at a very high level, what we're looking at now with our time and distance standards are there enough types and numbers of providers? And we just recognize that there's a lot more to look at there in terms of meeting consumer needs and identifying and tailoring networks to consumers. So I think that's what the next speaker is going to be talking about, kind of how we've looked at that and what particular characteristics we've looked at.
Thanks, Erika. All right. Thanks for, as Erika said, holding on to this last session here. We'll try to make this really interesting and worth your time. I'm sure you all probably had your moment of aha during the conference here, or moment of revelation. And for me, I had a moment of excitement when I walked to the desk of Office of Minority. And I picked up this leave behind from the desk which says CMS Framework for Health Equity 2022-2032. And immediately there's a definition for health equity in the document, and then there's also priorities. So there are two things that got me really excited here, which I wanted to share. One is I was frantically looking at the definition and kind of trying to line up that with this slide. If we really got this, again, you might think like, what's the big deal? But for a data nerd, trust me, like when your results are validated by an independent independent source, that's the best source of excitement for somebody who is into data. So it was very exciting to see like all the things that we mentioned in the characteristics that I listed here are very much in the definition document. And then the second thing in the priorities list, the very first priority that is listed here is expand the collection, reporting, and analysis of the standardized data. So again, that's a big win. Like I'm in the data side, so I'm Subhash Seelam. I'm responsible for applied network analytics at Quest Analytics, and at Quest, our mission is to improve access to care across all communities in America. And I'll be focusing, as part of this mission, I'll be focusing on the analytics portion of the health equity considerations here. So when it comes to measuring health equity, selecting the right characteristics is paramount, undoubtedly, right? And the task is very challenging because some of the characteristics are very difficult to capture, and they have intricate data nuances, which makes it even more challenging. And without data equity, there's not much we could do in the realm of health equity. So given these nuances, we are constantly looking to expand our data assets, and how do we either directly or through triangulation, get the right data to measure the characteristics in the most accurate way. That's kind of a key objective here. Now, it's essential to ensure that we are using the most relevant and impactful metrics in this process. So the model is designed to supplement the existing quantitative approach that is in place that Erika walked through, which is the time and distance, and helping regulators understand which counties have the greatest health equity needs, and then where there is more assistance necessary. So that's kind of the need for. That's how we've designed this model. Now, Quest is not only passionate about its mission, but it also has long been in measuring the time and distance adequacy requirement. So that's what gives us a very strong foundation. How do we build on top of existing time and distance adequacy requirements that we've already built? How do we layer on top of it the health equity foundation measures? Now, we are working hard to kind of find a nationally scalable data set for each of these characters that you have on the screen here. So the current network adequacy, again, as Erika mentioned, we have the time and distance, and for each provider type too, right? So we want to make sure, as an example, certain high needs specialties, like say child psychiatry. There's 2/3 of counties do not have a child in America, do not have a child psychiatry. So how do we measure this time and distance at that specific type level is important. And also essential community practitioners, like there is a minimum requirement. So how can we, the county is required to have some minimum percentage of ECPs to provide the provider types. So the first health equity characteristic that we focus on is provider race. Now, understanding that the racial composition of racial composition is very important. However, capturing this information is not easy just because of the nature of the measure here. So we have been working to kind of see how can we get a national database that is something that we can trust, reliable, it's sustainable, and in the long run we can really get to the accurate measurement of it. Access to public transit, again, this is a very important aspect. Like, I mean, one of the common reasons why some patients end up in an ER is like they defer care because they don't have proper transportation to the provider that they want to go to, and they defer care, and it could end up into some unfortunate event. So then cultural competency, as we've seen in the panel discussions earlier, like there's a lot of discussion around cultural competency. It's a very important component if we really have to attain the health equity standards. Then languages spoken. This is a very, again, important. Like I think there was an example earlier in the panel session. I think Dr. Sheshamani was giving this example where a Spanish-speaking person who walked in and lost vision because there was a language barrier. It's a really bad outcome. So language is a really important factor to get into proper health equity measurement. And then gender. The access to female provider is really important, and that is where we'll have to understand, like say, for example, little more than 1/3 of practitioners or providers are female. But then if you start to look at that statistic, underneath that statistic, and if you take OBGYN out, OBGYN is where you have 85+% of providers in that space. But then if you look at surgeons, only 22% of surgeons. Or if you look at cardiologists and orthopedic surgeons, there's less than 15% of the provider population are female in those specialties. So it's a very important factor how we have to assess that. And then access to high quality hospitals. These are CMS does rating of hospital star ratings, like on a scale of 1 through 5, 5 being the best. So how many members have access to a 4 and 5-star hospital? That's kind of an important aspect of it. Now, this is important because the star rating takes into account, it's heavily weighted. One of the weighted factors is HCAHPS survey. So if you really want to take patient feedback and bake that into this kind of health equity measurement, that's really important to address. So overall, I think we evaluated all these different factors and identified characteristics that have a highest correlation to the uneven distribution of access to care, and that's how we came to this. So our initial exploration involved gender, access to public transportation, and high quality hospital. The other factors, though, we have here, like we are still kind of finding right data source. So I'm going to hand it over to my colleague Kyle from AIR to talk about the county classifications.
Good afternoon, everyone. Thank you, Erika and Subhash, for setting the foundation for my discussion. So over the next several slides, I will be describing the work done by AIR and Quest to develop health equity county designations and explore provider characteristics in counties, and the use of both in the development of a model we call the Health Equity Index, which has the potential to explore consumers' access to providers with selected characteristics. Now, this is important work because we know that patients having access to providers that look like them and share common values and experiences tend to improve their adherence to care plans, which in the long term lead to improved health outcomes. Okay, so I'll describe a little bit about the work that AIR engaged in order to develop the health equity county designations. The first thing that we did was conduct an environmental scan. And we looked at several government sources and identified 6 health indices that have a relevance to health equity. The first one was the Minority Health Vulnerability Index. The next is the Area Deprivation Index, the county health rankings, the city health dashboard, the US News Healthiest Communities, and finally the Healthy Places Index. Now, all of them were at the national level except Healthy Places Index, which is based in California. And the criteria we use to determine which indices we would use were their relevance to health equity, their current use in the field, and the rigorousness and clarity of their methodology. Once we had identified the 6 indices that we want to explore, the next step was to identify which measures from those indices we would like to use in the process of developing the county designations. So we pulled together a panel of experts from various fields, which covered healthcare access, healthcare services, federal health policy, health equity, social epidemiology, pharmacy, healthcare analytics, network adequacy, and network design. That's a lot, I know, but we wanted to get a broad viewpoint from as many areas as possible. Now, once we had pulled together that expert panel, they went through a deliberate and robust process in order to identify which measures were closely related and had most relevance to health equity. So most of the measures were pulled from the Minority Social Vulnerability Index, and some measures were pulled from the other indices if they added any value to what we were trying to do. So from that work, they identified 58 measures within 6 main categories. And those 6 categories are SES, or socioeconomic status. And an example of a measure from that category was income level. Next category in which we got measures into were a household composition and disability. And an example of a measure from that category was the percentage of non-institutionalized civilians with a disability. The third category was the minority status and language. And this one is kind of explanatory. It covers race and ethnicity as well as language. And within language, we looked at several different languages. I'll just highlight a few of them: was Tagalog, Chinese, Russian, Arabic, and Spanish, just to name a few. And the fourth category was housing, transportation, and internet or computer access. And an example of a measure from that category was the dwelling unit type. Were individuals living in a multi-unit dwelling, or were they living in a mobile home or a single family home? The fifth category was healthcare infrastructure and access. And a few examples of some measures in that category were hospitals per 100,000, urgent care centers per 100,000, primary care physicians per 100,000, and mental health services per 100,000. And finally, the last category was medical vulnerability. And this category really dealt with the prevalence of chronic conditions within the communities. And a few examples of the measures we selected for this category were cardiovascular disease mortality per 100,000, the percent of diabetes among adults 18 years or older, and percent of cancer among adults 18 years or older. Now, the criteria that was used to select the measures were potential contribution to network adequacy goals. Secondly, the evidence-based connection of the measure to health equity, and the reliability of the data sources and methodology, and finally, the feasibility of a quantitative analysis. So once we had identified which measures we wanted to include in our analysis, the next step was to conduct weighting of those measures and those 6 categories. So the expert panel, again, we sent them individual tools where they would individually assign a weight to each of the 58 measures in 6 categories. Now, the criteria that we gave to them in their weighting exercise, firstly, was contributions, which is the extent to which the measure contributes to network adequacy policy and healthcare equity needs in the exchange population. The second criteria is usability, the extent to which the inclusion of the measure would inform potential future federal policy. And lastly, impact, which is the extent to which the measure would improve health equity. Now, once the expert panels had individually weighted each of the measures and categories, they sent that to us and we compiled their weightings for each of the measures and categories. And in reviewing, we would find outliers. And because there were outliers, we convened 4 sessions where we tried to get consensus among all of the experts on how each of the measures should be weighted. Now, those sessions were pretty robust in discussion. These people were passionate about this topic. And what they focused really on was how much does that measure impact health equity, and what should we assign their weights to each of the measures and categories. Now, I want to highlight that the ultimate goal of this research really is to help facilitate expanded access to healthcare for consumers. And therefore, the measures that provide insight into key indicators of health and have network adequacy and broader healthcare access implications, example, languages spoken, were weighted heavier than more broad measures such as poverty. Now, once we had a consensus on the weights for the measures and the categories, the next step was to calculate the composite score in each of the counties, the sample counties that we had. And we basically took the mean of all of the weighted scores from the experts, summed them for each of the counties to come up with the composite score. Now, once the composite score was determined for each of the counties, the next step was to categorize those counties based on their composite score. So we grouped the counties into 4 equally sized groups or quartiles. And what we saw were the groups, the lowest group from 0 to 25%, they were the ones with the increased access and had access to the resources and the infrastructure and had lower prevalence of chronic conditions. Whereas those in the top quartile, the 75% to 100%, they had lower access to health services and infrastructure and a higher prevalence of chronic conditions. So those at the highest quartiles were the highest health equity needs counties, and those in the lower quartiles were the lowest health equity need counties. Now, those between 25 and 75, they were in the middle of the road, so they were lower and high needs equity counties. So once we completed this work, the next step was for Quest to then take those health equity county designations for those counties and explore the access of consumers to providers with selected characteristics. So I'm going to now turn it back to Subhash, who is going to talk a little bit more about the work that Quest did to explore consumers' access to providers. Thank you.
Thanks, Kyle. I'm going to take a couple of minutes to kind of walk you through a sample of the dashboard report here. I'll start at this table that is marked as number 5, which is kind of connects to what Kyle just walked us through. So Kyle talked about the 4 county classifications, which is basically if a county has high needs, that's what it's mentioned as high at the top, and then the county has low health equity needs, that's mentioned as low in the lower side of the table here. So in this example, what you're seeing is there are 11 counties that are shown in the map, and there are 8 specialties. So each county specialty combination will get an outcome, and that's why you see 88 in the bottom right of the table. So each county specialty combination is measured against the county need. So if a county has a very high need, the threshold to meet that need is also higher, versus if a county has very low needs, the threshold will be a little lower on the lower end. So like how did we categorize them into this 4x4 grid? Basically, that's where I go back to number 2. So this is where you can actually see the standard adequacy is what we talked about already. So time and distance, ECP percentage. So that's already we talked about it. Transport. So the score is from 0 to 100. So the transportation score is 35.9. And this is a collection of all 11. But then on the top, if you can see, you can sub-select like a particular network or a particular specialty, particular county, and see how the score. That's where the dashboard becomes even more meaningful and provides regulators some insight into like where does the county need some assistance. And the female 84.4, that's reasonably high, but then depending on the county classification, that could be a pass or needs improvement. So now if you look at a health equity adequacy requirement, so there is a weighted calculation going on behind the scenes for all these 11 counties put together. The requirement is 53.6, but then the adequacy index is 50.1, so it's slightly below. But the 61.0 is basically telling there's potential if with corrective measures, if they are taken within these counties, the score can go up to 61.0. So that's kind of how each county is measured and then rolled up to the overall county overall selection level. So as you can see here, there is like 5 out of the 11 counties that did not meet, when the 6 of the 11 have actually met the requirement here. Again, there's a distribution. The fail base means I'm going by column in number 5 here. The fail base means they have failed in the adequacy requirements, the baseline requirement that we talked about, the time and distance requirement. And then the second column is failed health equity only. So meaning these are the counties that passed the baseline standard adequacy, but then did not meet the health equity requirement. So it's easy to then identify, okay, which specific counties are in there for what specialties. It's not that the county has failed on entirely, but there may be 1 or 2 specialties that they needed some attention. And then is that in this particular characteristic that I mentioned about like female providers or proximity to transportation or proximity to a hospital. And then we also have the same table laid out for each specialty. As I mentioned, there are 8 specialties that we are talking about here in this sample. So each specialty is listed. And again, the sum will always add up to 88. So it's just a different way of seeing. What this does is it allows the user to understand exactly which county specialty combination requires attention and what characteristics specifically that they need this attention on. So that is kind of the intent of it. Again, this is all exploratory discussion at this point. This is going to be an iterative process. Like it's not like one and done. So we are constantly evaluating and trying to find better ways of improving the accuracy of the model. End of the day, the integration of these additional characteristics into our framework is significant step towards achieving health equity from a data standpoint. And by leveraging the expertise from Quest Analytics and expanding our metrics and with the partnership with AIR, we are now better equipped to address the diverse needs of the communities we serve. So at this point, I'll hand over to my colleague from Families USA.
Thank you. I'm so appreciative of the work of both CMS and Quest and AIR in advancing this work. I'm glad to be with you, and I work in private coverage policy. With me are a number of my colleagues who work specifically on health equity at Families USA. We try to center health equity in all we do. We convene a health equity task force that makes recommendations on delivery and payment reform. And we provide a health equity fellowship, which applications are currently open if you happen to know healthcare providers that want to advance their policy skills and advocacy skills on behalf of consumers. We'd love to work with you. Network adequacy requirement standards are really important because they make a difference as to whether coverage really provides access to care. And that's why we've been working on it for a number of years. I want to call out a few services where network adequacy is especially important. One is behavioral health. 2/3 of African American and Latino adults and 80% of Asian and Pacific Islander adults report that they did not receive mental health treatment when it was needed. That's a very high percentage. Substance use disorder services and mental health services are distinct, and they must be separately examined. In both areas, people of color are underserved. The opioid death rate among American Indian or Alaska Natives and among Blacks remains much higher than for whites. And as we know from the fentanyl crisis, it is essential to have medication-assisted treatment and people who are well-trained to intervene. So we're really grateful that CMS data has begun to look more at these as distinct services, that substance abuse facilities are a distinct essential community provider that have to be accommodated in health plan networks. But we think that there's more that can be done and that you can advocate on this in both the state and federal level. Particularly, there are large gaps that in pediatric mental health services and pediatric substance use disorder providers, and neither of those services are looked at separately in federal network adequacy standards. And we hope that will change over the years, but there's also a lot of work that you can do on this at a state level. I'm reminded of this work because of my service on the DC Healthcare Ombudsman Committee. There's a dearth of residential addiction treatment facilities for substance use that accept adolescents. There are none in DC. There are some in the suburbs. But when people need these services, they're often denied, and it's one of the areas where prior authorization often comes to play in denying people services. So that's an area where we think that network adequacy standards can grow. And some states have gone further to specify the types of behavioral health providers that must be available and that must be accepting new patients. And there are a number of states, including Kansas, New Mexico, Delaware, Pennsylvania, Washington, and Arkansas, that are among states that have explored that. Another area for growth is in oral health, which might be through comprehensive or standalone plans. We're glad that children have access to oral health services now. We, in the future, states will be providing be including adult dental health services as an essential health benefit in some states. So how do people access these services? Are they in provider directories, especially if they're in standalone plans? Do people who come into an emergency room for treatment of pain for dental care get then referred to a provider who actually accepts their insurance? That's another area for growth. Reproductive care, we know maternal mortality rates are very high. We're interested in how doulas and midwives have been seen as an important resource for people with Medicaid, but doulas and midwives are not necessarily incorporated into private plan or marketplace plan networks yet. They might not be listed in provider directories. And to do an experiment, I looked at my own provider directory. I could find midwives, but I couldn't find doulas in my provider directory. And in general, we've wondered whether private plans are covering enabling services like peers and community health workers and doulas and midwives that have been shown to be so effective in various communities. They're not a replacement for other provider types, but they certainly help to bridge care and bring better outcomes. So the next category of work where we want to mention is just the role of plans themselves in helping people find network providers. We don't want ghost networks where providers are listed. We're not actually accepting patients. We want to make sure that provider directories are accurate and include information about providers that are available in other languages and providers that might be of the same ethnicity and background. Can people easily find the providers that speak their languages, and can they identify gender competent providers? And our Health Equity Task Force has mentioned this as a very important area now, especially where the reproductive care is very disparate across the country, and gender-specific care is also very disparate across the country, that people need to be able to identify providers that are friendly to them. And then can plan members also find out what accommodations providers make for people with disabilities? So one area where we think that plans can really grow their services is in helping people find available providers. For example, people in the middle of a mental health crisis do not need to be going through a provider directory or Psychology Today plus a provider directory and calling providers one by one to find out who has an available appointment. That should be a plan responsibility. And we really want plans to step up there. So over the years, we've really advocated for strengthened network adequacy providers and standards, and also for just strengthening of what plans do to help people. And we really invite you to join us in this work. We comment every year on the notice of benefit and payment proposed rules and the proposed letter to issuers. We're really grateful to CMS for listening to us so many times. In the coming year, state-based marketplaces are also going to be working to come up to federal standards. It's a perfect opportunity for you to advocate, not only for marketplace plans, but for all state licensed plans to improve their standards for network adequacy. So I'll close there, except to say that we would love to spread the word about your good initiatives too. So please contact us at Families USA. Thanks.
Great. Thank you all for sharing your perspective and experience with this, and for staying on time. Y'all did great. We have 10 or so minutes for questions. So if anyone has a question, you can raise hand. I know we're also going to be taking questions that come in virtually, but we have one up here in the front row. A mic will be coming to you, I believe. Just make sure you speak directly in the mic so everyone, including our virtual participants, can hear.
Hi, thank you. Good afternoon. My name is Erika Alexander, and I'm a U.S. Medical Director for Health Equity with Pfizer. And the question that I have is regarding the exploration of the characteristic types. Easy question. Did you publish that, or is that proprietary when you developed the dashboard and did the exploration?
Oh, yeah, I can take that. We haven't published that yet because we are still in very much in the exploratory phase at this point. Also, the reason is as I mentioned, it's important to get the right characteristics and also important to get the right data set to actually get the whole thing right. And we've been working hard to make sure we've got everything covered.
And I think the characteristics are pretty much aligned to a lot of discussion that I've been hearing in this conference. The data sets are a challenge, and as we get more comfortable in our validation process and all, at that point, I think we will be working closely with CMS to see if it's the right time to do a publication on it.
Great. No, thank you. Well, I really appreciated it.
Great. We have another one up front, and then we'll come back to you, sir.
Hi, my name is Raina. I'm a policy analyst with KFF, and I really, really enjoyed seeing that dashboard. I think it's great work. And it's just more of a question from my understanding. When you said fail base versus fail health equity only, just what is the difference between those two again?
Yeah, good question. So we are first measuring the standard adequacy that Erika walked through, right? The time and distance and all. I think the foundational to health equity index is like you need to meet the first time and distance and ECP percentage, like that's standard.
Oh.
If somebody has not met that standard, there is no point in measuring health equity because we wanted them to pass that. So fail base basically tells like you've not even done the time and distance standards. And then we wanted to separate them so it's easier to identify, like just because somebody has failed, if we bucket everything into one, it's hard to see, okay, is the attention necessary for time and distance, or is the attention necessary for health equity measures? So that's why we wanted to keep them separate, and that's why we report it.
Okay, thank you so much. Great work.
Great. We have one and towards the. Sorry, we'll come to you. I promise.
Hi, Ray Manhan with the City of Issaquah Equity Board in Seattle. One comment and hopefully some good questions. The comment, I think you gave us all reasons why surveys are really important. You had mentioned HCAHPS. That's part of kind of healthcare delivery survey that I think we should all fill out. Is any information, what other data sets, you have to start somewhere, right? So what is the census one of the other data sets that you're using just to assess what the needs are in any given zip code or a community? That's my first question. Where are these originating from?
So we used several different data sets that came from the American Community Survey, BRFSS. We got some data as well from the Community Health Rankings, from HRSA, for HEPSA, for high health professional service shortage areas. So we used a wide range of data sets. But if there are additional data sets that you are aware of that we should include, by all means, please share that with us.
Okay. And then, thank you. Is this driving how other plans like the United Healthcares, the Blue Cross Blue Shields, the Humanas, are they following standards that CMS created, or are they creating their own? Are you guys sharing your procedures with one another? How does that work out?
Sure, I can take that. So right now we're just doing internal exploration. There's a lot of different things you could do with this information. It doesn't necessarily have to work into network adequacy standards. It could be information that's shared with plans or with states to influence how provider networks are composed. But right now we're just doing internal exploration.
Okay. And I think you answered my last question, but these are all recommendations. They're not requirements. So if they're requirements, is there some sort of enforcement to say that you need to do this for this zip code in this state because they lack providers that serve this need? So how does
these are not requirements. Any requirement that we would impose on a qualified health plan would go through public comment.
Okay. All right. Thank you.
Great.
Hi, I'm Steve with the CMS Navigator Health Insurance Marketplace Navigator Program in Oklahoma. And as an elder, this is sounding a whole lot like KIPSA all over again. And so it's interesting that, as you mentioned, how much does this just simply correlate with the health provider shortage areas there? So it'll be interesting to see again how this gets implemented in terms of plans. One of the things that we see as a navigator is helping people choose among their marketplace plans. is that rural urban difference, because that's where network adequacy comes in. Now, that, especially for the specialists, tend to be concentrated in the cities. And so for our rural areas, if there's really going to be 40 different specialists on the list, that's going to be interesting to see whether anybody more than 100 miles from the biggest city meets network adequacy. Then the other part of that then is there going to be a star rating or something that lets especially rural folks know whether this is a good plan in terms of network adequacy as well. So looking ahead, especially for rural areas, since rural is part of CMS health equity definitions, and Oklahoma being a largely rural HIPSA state. So any comments on how this helps marketplace consumers to choose a plan that's going to work well in their area, and again, the specialties that are needed? Thanks for any comments and ideas for the future.
So the specialties, I mean, we're currently, enforcing that, and most of our health plans are meeting those criteria. If they're not, like I said, if there's a provider supply shortage, we take that into consideration. And there are some plans who come up with alternative access or ways to mitigate those shortages. In terms of the health equity information, like I mentioned, we're just doing internal exploration. There's a lot of different ways we could use the information. Some kind of consumer decision support tool may be a way. Also, classifying plans as meeting or not meeting health equity. That's all informational and could help in plan selection. So there's numerous different ways that an analysis like this could be used, but if we were going to use it in any way, we would regulate and seek public comment.
Great. We have time for one or two more questions, if there are any. Are there any on virtual? Can come up. Great. We have another one up front.
So when I think about health equity, I know that we're collecting data on race and probably ethnicity. Is there any thought on how we can consistently and reliably collect data on experiences of racism? Because race doesn't quite get at what we're looking for. And I haven't seen that applied in a way that, I would feel comfortable, except for maybe in a prospective kind of one-off way or very hyper locally. So what are your thoughts and what have you done in that space?
I can try that. So we haven't really looked into that racism to your question specifically. But this is not to say like this is all encompassing characteristics that it's going to really give you an index that is very much on the money kind of a thing, right? So the cultural competency, for example, is something like the providers that are within a community, like how much of what is going on in the community, like they understand how much of they know about the type of population that they're serving. I think being aware and some sort of a national training for providers to be aware of these kind of things. I think it's a collective effort. We're all three major stakeholders like providers, payers, and government, right? I mean, a collective effort to kind of bring up the literacy on health equity and what are the factors that they should be aware of. I think could help get us closer to a solution, solve those kind of things. Anything else?
I would add that, having increased access to providers that look at shared common experiences can also go a long way with kind of addressing the issue of racism in access to healthcare and
Right. We are pretty close on time, but want to open it up one more time if there are any questions. All right. Well, great questions from the audience. Thank you for your participation, and super big thank you to all of our panelists for sharing a lot of perspective and just all of your work on this really important topic. As we close this session, there are going to be closing remarks, the closing speaker for the entire conference. So you can stay in this room for that. That will be shown up on the screens. And let's just thank our panelists and thank you all for a great conference.